one. Hi guys. Yeah, it's pretty nice today, wasn't it? Day one for me. I've got 2 weeks here. So I'm going to present a few cases. I'm a cardiologist from Perth. And so we'll start with this one, which is probably my scariest case I reckon I've had. Is anyone here last year? Yeah. So anyway, there's a couple of slides from last year just about this sort of stuff, cardiac anatomy. So there's no laser pointer, but your heart, you have a right heart, a left heart, blood comes to the right, gets pumped to the lungs, that's the blue bit, comes back red, gets pumped out to the body. From the red bit, the oxygenated blood comes to the coronary arteries, the LAD, the circumflex that wraps around the back of the heart, and the right coronary artery. And then the ECG is how we look at the heart to see if there's a blocked artery, particularly for people with acute coronary syndrome. So if they've got a myocardial infarction or they've got ischemia of the heart, we can see it. So the ECG, I know a lot of you will know this, but I'll just go over it quickly. So you have the inferior leads, which look at the bottom of the heart. So if you have an inferior infarct, right coronary artery, ST elevation, and then the V leads are the anterior leads. And so if you have an infarct, you'll get elevation there, or depression if it's ischemia. And normal sinus rhythm, you can see, you have the atria contracting first and then the ventricles. So you have your little P wave, your atria, and then the big spike is the ventricular contraction. So ECG, and we look at, if there's ischemia, you get ST depression. We can skip through this quickly. And so, like I was saying, the ECG tells you which region of the heart is the problem. So this is a case of a 40-year-old woman who was having a meeting on Zoom when she got severe 9 out of 10 chest pain, going down into her arms, sweaty, clammy, felt like she was going to die. She's previously well, nothing wrong with her, she's got a couple of kids. She has no cardiac risk factors. So she called St John Ambulance, and they called us and said, we're bringing someone in who's having a heart attack. I was actually in the hospital. It was about 9 o'clock at night, doing someone else who was having a heart attack. And when she first turned up, she was hypotensive, and her pain sort of suddenly got better. And she said, I feel better. But she still had chest pain. So I finished the case I was doing, went down to see her, and she just had this ongoing niggly chest pain. So we get really worried about people that sound like they're having a heart attack and they've got no cardiac risk factors of females, because it's often this thing called spontaneous coronary artery dissection. So they get these little tears in their arteries. So you always don't want to do these cases, because I'll tell you why later on. You want to sort of go, do we really have to do this? Anyway, we had to do a ongoing chest pain. They'd done a CT scan while we're doing the upstanding, and they thought her coronaries were normal. So this is her ECG. I was saying before, you can see she's got ST depression, anterior leads. And then she sort of did this funny thing just as the pain got better, where she had this sort of funny rhythm, which is probably a ventricular sort of reperfusion injury. So you often get these sort of ventricular rhythms when you open up people's arteries. And then her ECG kind of got better, and this is when I saw her. So we took her to the cath lab to do an angiogram. So this is her right coronary artery, so you can see it's a really big artery. It's nice and smooth. Looks good. It's just, we do, because it's a 2-dimensional image of a 3-dimensional structure, you have to do orthogonal views. You've got to view it in different views to make sure that you're not missing something. And this is the left coronary artery. So you can see straight away how we inject the dye, and there's that big sort of flappy looking thing up the top. And then the rest of the artery just sort of isn't really filling, right, like it was on the other side. And then she said, I've got severe chest pain, and she promptly went into VF. And so we've gone radially, and you have to do it. This is just a tiny little catheter, and so you can't put anything down it, so you can't fix anything with that catheter. So when we went to pull it out, it was totally stuck, so she got spasm on the catheter. So we're doing CPR on this lady, she's in VF, we're shocking her, she stays in VF, she doesn't go back into sinus rhythm. So after we've been going for a few minutes, and you're going, right, this is problematic, then I've got getting access to a groin, because you can't go through the wrist, you need to put a bigger tube in. So I'm sort of thinking, what do I do? What do you do with someone that's got continuing VF? You can't get them back to sinus rhythm. By this stage, we've shocked her 3 or 4 times. We've got tubes in her legs. Does anyone have any ideas about what sort of support you could do other than CPR? So you could do ECMO. So ECMO is like putting someone on a bypass machine. The problem is you need a perfusionist. You need someone to run the machine. So you've got to call a code ECMO, and they've got to come into hospital and do it. The other thing about ECMO is that often with the dissections, they propagate down the artery. So when the surgeon gets there and tries to sew a graft into the artery, it's all dissected anyway. There's another type of pump. So I'll show you, this is the next shot. So we've been doing CPR, she's still actually in VF. We go up from her, because we can put a big tube, this is a guide catheter, and you can see that her artery's totally occluded. So that's what's happened. We've done the first shot, got these friable arteries, the artery's blocked off, she's gone into VF, she's getting no blood supply to the anterior part of her heart. And what actually happens is that the flap, the pressure of the blood in your CPR just pushes the flap open, so the true lumen, that bit of sort of the artery you could see from before, is totally blocked. And so it's everything you try and put down there, the wire, you have these wires that you try and gently put down the artery, is just in the flap. So while we're doing CPR, while we've called a code ECMO, waiting for people to come in, I did CPR for the first minute or two, then started doing a tube in the legs. So you've got to try and get in the true lumen. It's really hard because you just can't see it filling. So changing catheters, trying to wire it from way outside in the aorta so that you can try and find where that flap is. And also when you inject us, that's just a little test dose, you can make things worse. So this is what the sort of options are. You have a balloon pump, but it's a counter-pulsation pump. So when you're doing CPR, it helps because when you push and increase the pressure, it senses it and it will pump. But it's not going to fix a artery down the front of the heart. That's still going to be ischemic. There's this device called an impeller. So you put it in through the leg and it's got a little axial pump and it pumps out blood, but it only really does sort of 2.5, 3 litres a minute, and it's not really enough to keep you alive, and she's still going to be blocking off her artery. And then the last thing is ECMO, so basically putting them on bypass, big tubes in the legs. But as I said, you need someone to come in. So we called a code ECMO and continued CPR. The cath lab staff were amazing. We did 15 minutes, I think, of CPR. So she'd been shocked about 15 times. Every time we shocked her, just stayed in VF. Never had any sinus rhythm until about the 15th shock. So here, this is what happens with a dissection, with the coronary artery dissection. So they're usually young women, or women more predominantly, often don't have cardiac risk factors. And whatever happens is you either get a spontaneous bleed in the wall of the artery, and the flap folds in because of the pressure of the artery and occludes it, or you actually get a tear in the artery and then the pressure of the blood spreads and blocks the artery off. I'm going to trip over that eventually, aren't I? And this is sort of called optical coherence tomography. This is IVUS, OCT, and you can see that's the normal lumen, the bright yellow, and the big sort of dark bit, the FL is the false lumen. So we've just got a, the guide catheter is actually sitting in the false lumen, so we're never going to get into the true lumen. And they're just some more pictures of, what it looks like, squashing the arteries just full of dead space. Anyway, so about 15th shock, she stays in sinus rhythm. She's got a blood pressure of about 50 in sinus rhythm. The anaesthetist turned up about, we've been going for probably about 8 or 9 minutes doing CPR. And I said to them, so the other thing was when we're doing CPR, because hasn't really, she's arrested and we started CPR straight away, she's getting perfusion to her brain. She's crying out in pain and trying to pull my hands off her chest when I'm doing CPR for the first minute or two. Then we changed to her leg, she's trying to get off the bed. So she's still in the DF. The only reason she's getting, just because we're doing good CPR, is getting some perfusion to her brain. So she's sort of out of it, but still trying to get up off the table, groaning. So the anaesthetist, I said, look, when he turned up, I said, you've got to intubate her so we can do CPR. Put on, a Lucas device, the pump, so we can get on. He said, I'm not going to intubate her, I'll kill her. It's like, she's dead. You have to do this. You can't do CPR unless you do it. Anyway, so they eventually did intubate her. And so what happened is, you can see there, the 15th time we shocked her, I can't go back. What do I do? Click on, sorry Quentin, that one. After the 15th time we shocked her, so I've got a different balloon, put a big stent in there just to hold the artery open and scaffold it. So you can see you put a wire down the other branch because you've got a flap there, and you put a stent in there. Often you push the flap and close off the other branch. And so you can see here how that branch is just sort of being held open by the wire there. And the stent is probably, put a big stent in there. You can see right at the end of the stent, down here it looks slightly, like the stent's slightly oversized from the artery. So about this time the surgeon was there and they said, do you need this? And I went, I think we're okay. We don't need to put on ECMO machines, that was good. So then we put a wire down that diagonal branch, so you just got to make sure you're in the bit you want to be in. Then you can pull that wire, the first wire's trapped outside the stent, so you've got to get rid of that. Then you've got to wire it from inside the stent. And we just put a balloon in, and we kiss it all open, and we're looking pretty good. Except that bit where it looked a bit oversized, now she's got a dissection down there too. But she's not in VF, so that's good. So another stent, just to tack that up, a bit smaller this time. Looking good, feeling better. I'll be able to go home and go to sleep. And so this is an iris catheter, so it's a little ultrasound device that you actually put down the artery. And so we can see that, we've done a good job, that we haven't left any splits. So you can see this is totally normal artery here. So you have this intima, the inner layer, that you can't even see before the muscle bit, which is the black line. The white, bright bits of the stent. There's a branch coming off. And it's all looking good. Right at the top, the stent was just slightly undersized. So we know we've just got to push the stent out because you don't want to have a gap between the stent and that artery wall, otherwise blood clot can form there and then you can get stent thrombosis. Looking good, a little bit undersized right at the top. We can probably skip through just for time's sake. So just a little tiny gap there. So we just put a little balloon at the top, balloon it, and it looks good. Wire's out. finish. Anaesthetist was there, so we put a toe probe down because he's intubated. Just have a look at the heart, and it's all looking pretty good. This septal wall and anterior wall that's supplied by the LAD, it's all a bit hyperkinetic, so there's bits of the heart, but overall, ECG is back to normal. And I came in to see her at 7:30 in the morning. We left at about midnight. She'd been extubated. She was eating breakfast. Her chest was a bit sore because she had 15 minutes of CPR. She had a mildly impaired ventricle. This is definity contrast, so it's this ultrasound. There are these tiny micro bubbles that you can inject, and so it just gives you endocardial definition. So if you're not quite sure, you can put this in. And she's just got some mild, that one's not playing it well. She's just got some mild hyperkinesis. It's not contracting quite as well. So then, spontaneous coronary artery section. For younger people that get it, they often have other vascular abnormalities. So it's like a systemic condition. So the heart is just how it presents, because blocking off your artery in your heart's always bad. But this is her carotid artery, and you can just see how it looks much bigger there. And it was reported as a dissection, but the vascular surgeons actually thought that it's just sort of ectatic. So you get this sort of, just like in old people, they sort of get the aorta that sort of all winds around. That's what happens to younger people with this spontaneous coronary artery section, or a predisposing condition like fibromuscular dysplasia, which is what she's got. So it's a non-traumatic, non-iatrogenic, means I didn't do it, separation of the coronary arterial wall. It's about 0.5% of people rocking up with chest pain and non-STEMIs and myocardial infarctions. It's much more common in younger females presenting with acute coronary syndrome. It's true instances probably unreported because we fail to recognise it sometimes. We'll see sort of a narrowing and think, oh, that's just coronary artery disease, but in fact, it's sort of a bleed into the wall, and that sort of narrows the artery down. And you should do another angiogram on that, it all looks better. So for women under 50 years of age, it's thought to be the cause of about 1/4 of cases. So it's often postmenopausal women as well, and it's much more common in women. So you can see there's sort of almost 90% predominance of women. So it's much less common in men. And in those men that get it, it's probably the dissection is actually due to them having plaque there and just getting a little tunneling into the artery due to the plaque. So it's a totally different process. So we sort of discussed all that stuff. There's some sort of predisposition in lots of cases. Fibromuscular dysplasia is probably the most common one. So we screen everyone that comes in with a SCAD, we scan their carotids, do a CT scan of the renal arteries, and it's very common to find abnormalities in the other blood vessels. There's often some sort of history of stress, a bit like Takotsubo cardiomyopathy. There's some stressful event or heavy exertion that predisposes it. There's definitely a hormonal component, can be related to high dose progesterone, estrogen, can be related to pregnancy. People often have migraines with it. So consider it in young females. We usually make the diagnosis at the time of angiography. So we try to manage it conservatively. A lot of patients will present with chest pain that then settles down. We do the angiogram, they've got SCAD. We try to not do anything, even if there's like a 70-80% narrowing. If they're not getting chest pain at the time, they heal up and then the artery looks normal afterwards. We only do things if we have to do them, like the patient's arresting or they've got ST elevation, they've got ongoing chest pain. And the reason for that is that the arteries are sort of friable and soft, and like you saw when you put the stent in, you can either split further down. So you really want to try and do nothing if you can. They have a much lesser output, so worse outcome. So someone comes in with a non-STEMI or a heart attack, we get a successful result like 98% of the time, statistically. whereas you can see it's 70% of patients. So we just don't do as good a job because of the vessel fragility. Size in the artery, lots of reasons why we might not get a great outcome. You've seen the acute sequela, you are having a heart attack, you can have bad heart rhythms, you have shock, you have all of those things. For most cases, the mortality is only about 4%. The long-term sequela are you've had a heart attack and you're at risk of having further episodes, so 10 to 17%. So it's kind of a scary condition because people get on the internet and see that there's a chance of recurrence and everyone gets worried about that. Beta blockers are helpful, a bit like dilated ascending aortas. You reduce the wall stress in the artery. So we give patients beta blockers, we give them antiplatelets, especially if they've got a stent and they need two. If they don't get a stent, we tend to give dual antiplatelets anyhow for some period of time. But these arteries, they actually heal up really quickly. So you can do a repeat angiogram a few weeks down the track and it can all look normal. So it's a quote from one of my colleagues: when you think you're screwed, you're only halfway screwed. So if you've actually got time to think about it, don't give up, keep trying. I was just going to quickly show a different case. Does anyone want to have a ping at that ECG? It's fast. VT? Yep. So it looks like VT, doesn't it? Fast, regular, so it's what? Different types of VT. Monomorphic, polymorphic. So mono, so it sort of looks the same, right? There's polymorphic VT where it sort of changes all the time, whereas this, you can see on the bottom line, it all looks pretty much the same. So this is I'm just showing this because it's another type of dissection basically. This is a 48-year-old Indian guy who's come to visit his family, doesn't speak any English. He's been unwell for 3 days and comes into hospital. He's hypotensive, and he gets a shock and goes back to normal rhythm. He was hypotensive and his GCS was impaired, and so we got called to come and see him. You can see on his ECG here. Does anyone want to have a shout out what they reckon is going on there? Anything to worry about? Is it normal? He's got a bit of ST elevation in the inferior leads. He's got these big Q waves. So Q waves are often a sign of scar that it's whatever's been there's been there for a long time or long enough for it to be infarcted. But we took him to the cath lab because he's hypotensive. Actually, when we got there, he actually improved quite a lot. And I did an echo as we were putting him on the table, and you can see the inferior wall and infralateral wall. This is all thinned and not contracting that well. You see here, this inferior wall. It looks a bit bright. It kind of looks like maybe it's been like that for a while. And so this is his right coronary artery. So you can see it's a huge vessel. And he's got this big line, or sort of a series of lines in that proximal bit. It's a bit weird. So I sort of thought, that looks like a dissection, but it's kind of funny looking. His other artery was good. So when we wired it, you can see I was having a bit of trouble getting it to go down a little bit further, twisting, turning. Do a little puff of contrast in a second, and you can sort of see, oh yeah, go down that way, and off you go. And so this is his iris, this is his intravascular ultrasound, and you see in a second, you see there's all these multiple lumens, this whole sort of area, it looks like Swiss cheese. So he's obviously had some chronic sort of dissection that's healed, and then he's blocked it off again. Bit of hard work getting a stent down, so we had to sort of take the stent out and balloon it all again. stent in just to cover all of that area, because on this IVUS we knew it was really extensive. And anyway, it all looked good. After we put the stent, so you get a good result. So that's a different type of dissection.